Hi there. My name is Ashish Khanna for the Society of Critical Care Medicine. Today, I have the honor and distinct pleasure of speaking with Sarah Monchar. Sarah is a trauma critical care PA for about 10 years now and is also the trauma program manager at the Hackensack Medical Center in New Jersey. So, Sarah, tell me in very simple words, how is it at the front lines? What is your typical day as a COVID-19 ICU provider?
So the only way I can describe it, and I do this with sensitivity to people who have actually been in the military, is that it feels like a war zone. And I say that having never been in a war zone, so I can appreciate that, but it doesn't feel like anything we've ever been used to. The schedules are sort of out the door, the 8 a.m. morning report, everything we've been used to. It's just really survival mode is what I feel like. It's all hands on deck. Doesn't matter what your credentials say, or you might have worked in one area and someone else worked. It's everyone is just in it for the minute, and whatever we need at that minute, that's what you're doing. Our main goal has to not stress one particular person, that it's teamwork, and the only way we're going to get through this is by spreading out the work. Because to have, if one unit is heavier than the other unit, we'll actually just pull resources from the lighter unit at that minute and go to the heavier unit, because it's so important to not burn out your frontline staff. And so that's really been what we've tried to do. So, as a manager, I try and make sure that the people on my team are getting the time off that they need, and that they are leaving on time, and that they're getting fed, and that they're sleeping, and all of the things that we need to do so that, we can come back the next day and round again.
How about some other specific challenges that you'd like to share with the audience today?
Yeah, I think one of the biggest challenges is the unknown. So we're so used to evidence-based practice, and since graduating, that's all I've heard about, and everything we do in the ICU and every change we would make in ARDS or sepsis, we were always quoting a paper and looking at the resources. And here you've now been thrown into an environment where no one knows anything. I mean, we take what we can from Italy and from China, but every day our guidelines are changing. And some of the guidelines are experimental because we don't know. There are certainly, when you talk about outcomes, there are no outcomes yet, So I think that we're doing our best, and we have a lot of different ideas, but we look to what we do have. But that, to me, is one of the biggest challenges, is the unknown. In the beginning, we thought that patients were behaving like ARDS, and so you manage them like you would your ARDS patients. But now we're starting to think that it's more of an inflammatory process, and maybe what we were doing in the beginning with ARDS isn't exactly what they need, and no two patients are the same. One of the other pitfalls is not getting tunnel vision on COVID. That sometimes you just manage with your COVID guidelines, but you forget that this patient may be having an MI underneath everything, or maybe coming in as a DKA patient with COVID. And we've seen a lot of those patients where you have to remember, like, okay, now I have heart failure in COVID, I have DKA in COVID, I have, Takotsubo cardiomyopathy with an EF of 20 with COVID. How am I doing things differently? And so there's really no cookie cutter approach. As much as you try and follow the guidelines, it's so important to have a systematic way of looking at each patient, so that COVID is only a piece of that patient. And you don't fall into that trap of, sort of treating all the COVID patients the same way, which is easy to do when you have 100 patients and they all look so similar and have the same story.